Hello, everyone, and welcome. I'm Sylvia Oakland. I'm a staff writer here at GovCIO Media and Research. We are live at the Health IT Summit, and I'm here with Kyle Cobb, the Acting Deputy Director of Product and Technology at OPHDST within the CDC. We just got done listening to your panel, and I'm really glad to have you here on the show today. Why don't we go ahead and dive in, just what's fresh off your mind as you're coming out of your panel?
Well, I'll tell you that my panel is about APIs and how APIs are supporting interoperability, and having actually previously been at ASTP or ONC before I came to CDC, it was a big part of my life at ONC launching the Open API regulation, and it has spawned and pushed forward interoperability in ways that are really magical. I think to the point that we're really thinking critically about how many connections we need to accomplish tasks. Mm-hmm. So, for example, should hospitals have point-to-point connections on hospital A to B to C to D, and how does that actually work? Or do you have a hub-and-spoke model? Right? And so we're really trying to get to a hub-and-spoke model where you have a central data authority or data utility that's able to call, link, and have data together. So it's all possible by APIs. And so what's also exciting for me, and we didn't talk about much on the panel, but the ability of where we are with FHIR now, mm-hmm. To have these, query and response, bulk loads, we're able to also do subscriptions. So if you want to have some sort of an alert on a data set, for a condition, for example, a reportable condition for case reporting, you could actually have that trigger list. You could move it off of the EHR and into a data utility.
Wow.
So that's a huge economy of speed, because all of a sudden we talked before about how fragmented people's care is and how many different health systems they go through, different EHRs, which, makes a lot more noise and more points to connect if you're looking for reportable conditions, for example.
Yeah, and I think the next thing that I want to get into is the public health data strategy and its milestones. When I first reported on that when it came out, there was just so many good nuggets of information in there, and there are some really good, guidance and some really good ways to look at the reporting side and see, the measures and metrics. So I was wondering if you could talk about some of those milestones in regards to interoperability, and especially as we're seeing, I've said multiple times today, but HHS's open data plan is really a driving force of this. So interoperability and open data.
Yeah. So for sure. So last year we had milestones for TEFCA, and we were able to see stilts or state, local, tribal, and regional public health authorities actually use the TEFCA network to send case notifications. We did not close the loop and have additional reporting to CDC as part of that. But now this year, we're looking at a slightly different pilot with the Implementation Center project, where we will be pairing health data utilities with public health and to work on exactly this, establishing case reporting trigger lists within the data utility so that that information can be routed to public health.
Yeah, so really looking at a way to make this more holistic and getting, all of this information that we can, but also making sure that we're using it and it's getting to the places that it needs to get to.
And reducing the number of connections, right? And by using one central repository for all of the data needs, whether it's through healthcare or through public health, it actually is an incredible economy.
Yeah, and I think that leads right into this next question of increasing collaboration. I read some of your work beforehand, looking at that state, tribal, local, and territorial, and just what that looks like in reducing burden, whether, it's the clinician, it's someone, at a regional office of the CDC. What does that increased collaboration look like, and what are some of the benefits you're noticing from it?
Well, we've been working on a core DUA, and that may have been something that you've learned about in the past as part of our public health data strategy, but it is to have the same and core DUA agreement with each of the states, which allows for consistent and standard data collection and minimum data necessary. So that actually enables us through just APIs in general to have a common understanding of what that data set is. And we can actually move that to really link healthcare data to stilts by saying, these are the data that you care about within the public health domain, but guess what? They're all within healthcare, and we can move them to you without, special effort.
Yeah, I was talking with a couple of panelists before we went up on stage, just talking about, how do we we almost need to do like a SWOT analysis of this is what we need, this is what we have, here's where we want to go, and here's where we've been. Just to kind of get the lay of the land, both in that, in the present, in the future, and in the past, to bring that all together.
Context is everything, and we talked a little bit on stage about how, this has been an incredible journey, right? And 15 years ago, we started with EHRs and meaningful use, and that did not really think about interoperability at the time. EHRs had core capabilities that they had to conform to produce some analytics. And now we are actually saying, and Avinash had shared this, that ONC or ASTP is now saying, we don't really care about those capabilities as long as you use the data standards.
Right. And again, I think that's one thing I'm hearing, whether it is in the healthcare sector, whether it's in the civilian sector, whether it's in the defense sector, it is that we have to have this data and these data standards, right? There was something my cross-country coach used to say, and it was, you only get out what you put in. We called it yoga whippy. And that is the one thing that I think about when it comes to setting these data standards. Yeah. And so what do you kind of see as some of these barriers, but maybe also some opportunities in that burden reduction as we're talking about, all of these different strategies and standards?
So I'll start with the barriers, because I think those are real and worth, just touching upon. There's some of the tension between public health and healthcare has been that public health has felt that the data quality is not as good as it could be. And I'm sure this goes the same for healthcare providers as well, right? We know that data quality is an issue. Once we start using standards like USCDI, we can create data, quality dashboards and start looking at the data. I think that we're at a juncture now where the more that we can look at it and analyze and understand what we have will get us to a better place. I think that that's really going to be key for public health, to understand what the data is, how it's coming, but also see a quality dashboard to really understand within each of the data domains, how strong is it?
Yeah, and this is kind of the last question that I've been leaving all of my panelists, all of my my interviewees with is, what is the role of AI? We had generative AI last year. We're getting to agentic AI this year. And some of the people I've talked with, they talk about reaching that relationship of AI and the human workforce. And, that's a goal that we're definitely going to get to. But what is AI's role right now for you and your team?
So we've actually seen, there's a stilt right now doing this, but they're using AI to parse CCDA, which is a standard format that EHRs use to transmit data. It's an older format, and they're using AI to transform it into FHIR bundles, which is a better standard for right now, and a more modern and extensible standard that we would like everybody to be on. But, changing standards is hard. But all of a sudden with AI, we can actually flip some of those older standards and modernize them.
Yeah, and how do you
which is incredible, right? I mean, it means that for any type of an LLM, all of a sudden we have huge swaths of data, which we haven't had historically. And I think, this was my comment on the panel. It is exciting to see where we'll go with all of this. I mean, we're on the precipice. So it's really having access to the data, being able to spin up LLMs with real world data that we've never been able to access people.
Yeah, it's a really exciting time, and I'm so glad that you were able to share your insights over at CDC. Kyle, thank you again so much for joining us.
Thanks so much.